what do you do when a patient has a high suspicion MRI and the biopsy comes back negative? I'll first start by saying that, I often feel that I'm viewed as sort of MRI's defense attorney, but I am not, and I don't get anything out of you doing an MRI, but I do think it's a good tool, and I think it's worthwhile for us to understand its value and, of course, its limitations in practice. A few disclosures listed here, none of which are specifically related to this talk. So when I put this talk together, I actually had to shift what I normally talk about. What we're normally talking about and focused on and perseverating on is the cancers that MRI misses. This is really more about the cancers that MRI should be finding. And if you have a PI-RADS 4 or 5 abnormality, what should really be the positive predictive value of that? So why would an MRI-targeted biopsy for a high suspicion MRI be benign? Well, there are simply two reasons. One, either the MRI is wrong, or two, the biopsy is wrong. And a false positive MRI can be driven by confounders including focal inflammation, nodular BPH, premalignant findings, anatomic variants. And of course, reader inexperience and overinterpretation remains the Achilles heel of MRI in clinical practice. There can be poor MRI resolution, poor protocoling, which drives this as well. False negative biopsies can be related to targeting error. That can be a function of the registration on fusion. It can be a function of operator experience, and of course, inadequate sampling, as we've been hearing about this morning a bit as well. So I'll try to touch on all of these issues. So early work in MRI really taught us a few things. So, this is going back now 15 years that we've been evaluating MRI. We know there's improved specificity through multiple functional parameters. It's quite good at localizing some tumors. And we know that the presence of tumor on imaging predicts worsened disease outcomes. So it can predict a higher likelihood of recurrence after surgery. It can predict a greater likelihood of progression after surveillance. And for many of us, we've believed that this means disease you see may be more biologically relevant to the patient than disease you don't see. That remains to be proven, but there's ongoing genomic work which I think will ultimately show that. MRI protocol, technique, magnet strength, they all influence the imaging quality and the ability to detect disease. And of course, quantitative metrics are utilized now. Suspicion score, which has been converted to the PI-RADS score, and ADC values can help to quantitate risk on the MRI. We know that when we look at apparent diffusion coefficient, which is the quantitative metric of MRI diffusion imaging, we know that it correlates quite well with aggressiveness of cancer, but you can see how widely the confidence intervals overlap. So somebody with an ADC of 1 could have low, intermediate, or high-grade disease, and as such, MRI is still not to the point where one could use it for Gleason scoring or aggressiveness as an example, and it probably never will be, but it can tell us the likelihood that disease is present. We learned very early on, this is from a paper that I think Andy Rosenkrantz and I wrote in 2010, that some tumor is tumor you see and some tumor you don't see. So in this case, we see a gentleman with left apical disease that's quite evident on T2-weighted imaging on the left and ADC imaging on the right, but on the contralateral side, similarly has Gleason 6 disease, which is not evident. And we were very interested to understand what's the difference. Not sure we still understand what the difference is, but we do know that certain things correlate with the likelihood of visibility. Size of tumor, Gleason score, presence of morphologic patterns, including solid tumor growth, desmoplastic stroma, and a high ratio of epithelium to stroma. Whether those indicate a more aggressive cancer or not is unclear, but clearly you can have some sense of why you would see a disease in some cases and not in others. Now, the PROMISE study, which was alluded to this morning, is an important study to understand the predictive accuracy of MRI. It's critically important to understand this tells us nothing about MRI-targeted biopsy. This was a study of MRI. And what was done was that gentlemen underwent an MRI, and then prediction of whether they had cancer or not, and then ultimately underwent an extensive saturation template biopsy to determine the presence of cancer. It's important to note that the template biopsy found cancer in 41% of men in this study, which is similar to what you would expect with sort of a true incidence, if you will. And so we believe the template is a good reference standard in this case. And what was found was that of men who were predicted to have clinically significant cancer, there was a 49% false positive rate on the biopsy. So that's important. People, again, usually focus on the negative predictive value, but the positive predictive value of MRI is not perfect either. That's saying that if you have an MRI abnormality suspicious for cancer, this is independent of PI-RADS, about 50% of them will not have it. Now, this is related to their definition, which was Gleason 4+3 and clinically significant cancer of greater than 6 millimeters. So I went back and looked through the data and resampled it to assess positive predictive value based on different definitions of clinical significance. And if you use the more commonly utilized Gleason 3+4, any Gleason 3+4 as clinically significant, then the positive predictive value improves to 65% on the template biopsy, but not perfect. What influences positive predictive value? Well, the definition, as I just told you, interestingly, the indication for biopsy, the prevalence of disease in the sampled cohort would influence it, so the indication for biopsy will influence the prevalence, but also parameters like PSA, age, gland size, and of course biopsy technique and operator skill. Our data at NYU has been informed by our approach. Since May 2012, we have been committed to every man coming to our institution getting a pre-biopsy MRI, enrolling in a prospective comparative study, transrectal ultrasound guided biopsy. Typically that's been transrectal fusion. More recently there's been a shift towards transperineal fusion. What we learned early on was that the biopsy indication was strongly influential with regard to the positive predictive value or the likelihood of finding clinically significant disease. And so if we focus in this case on our patient with PI-RAD4, you can see that depending on whether that man has had previous biopsies or not, the likelihood of significant disease in red varies. And that relates to a very common phenomenon, which is that any diagnostic test, the more prevalence of disease there is in the test population, the positive predictive value will go up. The negative predictive value will go down. And that relates, for example, to the slide that Dr. Stone showed, the infamous study from UCLA, where they looked at whole mounts of radical prostatectomies and said, look how much disease is being missed. Well, that was a group with 100% prevalence. So you would expect the negative predictive value of a diagnostic test to be poor in that very selected group. In the setting of positive predictive value, it goes up among previous negative biopsy, biopsy naive, and active surveillance, and our data at NYU supports this. So for example, in a PI-RAD4 setting, there's only a 39% positive predictive value with a previous negative biopsy, 55% with biopsy naive, and around 50% with active surveillance, whereas PI-RAD5, interestingly, is consistently high positive predictive value regardless of the indication. So what this tells me is that not every PI-RAD4 is cancer, right? And in fact, in men who have lower prevalence, it's more often not cancer than it is. Now, we've tried to further refine that risk using a nomogram we built a few years ago, where we incorporate volume, density, suspicion score, and what you can see is that if we take a gentleman, in this case, who has a PSA of 5, a volume of 40, and his suspicion score is 4, his positive predictive value or suspicion goes up to 77% from the 50% that I showed you before. So clinical factors can influence risk as well and probably should be incorporated when you're determining the likelihood that your biopsy is wrong. When we look at our own data from the biopsy naive cohort, this is how it segregates. This is our early experience, but it's not much different now. Among men who are PI-RAD4 and 5, about 60% have clinically significant disease with PI-RAD4 and about 85% with PI-RAD5. The Achilles heel, though, of course, is here in the red. This is a 4x4 table, and at the top you can see targeted biopsy outcomes. On the left, you can see systematic biopsy outcomes in the same patient. The pro of the targeted is these patients in the green that have high-grade disease detected only on the targeted biopsy, but there still are a subset of men in whom the targeted biopsy doesn't demonstrate high-grade disease, but the systematic does. And so that probably refers to the missed cancers we talk about, and that probably refers to what we're worried about if our PI-RAD4, PI-RAD5 patient comes back with a benign biopsy. That can be influenced by how we sample the prostate. So you've already heard there are a number of ways of sampling a prostate, saturation techniques, but within the realm of MRI targeting under ultrasound guidance, there's visual estimation, cognitive co-registration, which basically means that you, in your own mind, estimate where the MRI abnormality is and you focally saturate that area. There's fusion software co-registration. There's in-bore MRI-guided biopsies, which are done by the radiologist. So the distinction between MRI targeted and MRI guided is whether it's done in the bore, and then, of course, the saturation techniques. I'm going to spend the next few minutes trying to tell you how I think the MRI targeted biopsy technique might influence the likelihood of a false negative biopsy. Very early on, when we were first evaluating fusion, we did a study called the Profuse study, which was published now about 7 years ago. What we did was basically do biopsies in men in which one surgeon would go in and do a fusion targeted biopsy, and then another surgeon would come in and do a visual targeted biopsy blinded to the results of the fusion, and then a 12-core biopsy. And we compared visual targeting with fusion. We showed equivalence, although the p-value you can see comes pretty close to significance, and we may have just been underpowered. But across the board, regardless of indication, in the purple, you can see clinically significant cancer was more often found with fusion than visual. And so this was what prompted us to say, well, look, we think fusion is the better way to go in our hands. When we did a multivariate analysis, what we learned is where fusion really helps you is in the anterior prostate, where visual targeting may be more difficult owing to more difficult visualization, and in small ROI regions that are under a centimeter in size. Their fusion is probably helpful. We've also learned that fusion is a technique that requires skill. It's a surgical procedure. I think as urologists, we have far too long viewed biopsy as sort of a meaningless procedure that can be done by our techs or our assistants. It's a surgical procedure that requires skill just like anything else. And we published that in our own hands, for every, I think this is 180 biopsies, this dot, our PI-RAD4 detection rate went up over time. Now, some of that may relate to improved imaging, but certainly some of it relates to improved technique. The other way we look at that data is that in that study, in the first 200 biopsies, we missed 4% of GG3 cancers, and in the last 200 we missed none, and our undergrading rates relative to systematic biopsy were reduced as well. So targeting improves with time, and that may reduce the likelihood of a false negative biopsy. So when we've done biopsies, we've often asked the question, well, what is the negative predictive value in terms of accuracy? So what I mean by that is not really negative predictive value, but negative accuracy. If you have a negative biopsy, how confident you should be. It's hard to determine that, of course, without doing prostatectomies after you've done the biopsy, but we've tried to define it by the rate of cancer identified on a repeat MRI-targeted biopsy, and we've utilized our active surveillance population in whom we see upgrading in about 25% when we do a repeat targeted biopsy a year after the first. And so let me show you what I mean by that. This is the outcomes of repeat MRI fusion biopsy 18 months after the first fusion biopsy, and what you see is concordant findings in only about half, downgrade or no cancer in 13%, and upgrade or new cancer in 35%. So you see targeting accuracy does play to some extent into this, and what we find is that upgrade when it occurs can be as high as GG3 from our GG1 patients on surveillance. This is upgrade risk is predicted by PI-RADS, of course, and so if you look on the right, PI-RAD 4 and 5, the rates of newly detected Gleason 7 cancers or higher is pretty significant. So what it tells you is that when you have a negative targeted sample for 4 or 5, if the 4 or 5 persists, you should probably be worried you may have missed something. This is a recent analysis we did where we looked at the cancers we miss on MRI-targeted biopsy relative to systematic biopsy, and we found that particularly for high-grade cancers, in most cases, the cancer is ipsilateral to the index tumor, again reflecting a likelihood that that simply represents targeting error or undersampling. Now, one of the things we published a few years ago was the interaction of ultrasound with MRI. And so this is a study in which we, for several years, I've now prospectively recorded the results of the ultrasound at the time of fusion. And we've created a scale where we see no hypoechoic lesion, a poorly demarcated hypoechoic lesion, or a well-demarcated hypoechoic lesion at the site of the MRI fusion. So on the right, you see here a gentleman in panel A and B who has a pretty large T2 signal intensity tumor on the left, a smaller tumor just at the interface of the transition on the right, and this shows up in the middle panels on the diffusion quite well. And then here on the ultrasound, you can see a corresponding hypoechoic abnormality in both locations. When we look at that data, what we found was that the presence of an ultrasound abnormality at the site of the fusion in and of itself was predictive of the likelihood of clinically significant cancer. Now, I don't think that's biologic. I think that means if you see it, you target it better, right? And so this, to us, has indicated, and here you see the interaction of PI-RADS and ultrasound grade, and you see that even independent of PI-RADS, ultrasound grade is predictive of the likelihood of clinically significant cancer. Some of that may mean that these are worse cancers when you can see them on ultrasound, but to me it means that you need to use visual cues at the time of your fusion. It should be a combination of visual estimation and fusion to maximize your sampling. Finally, how many cores do you take? Well, when we do fusion-targeted biopsies, we've traditionally, just because we did 4 in the Profuse study, we've always done 4. And we asked the question, is that worthwhile to do? And in fact, majority of patients are found to have FHGC stands for first highest Gleason score, and FCSC stands for first core that's clinically significant cancer. You can see the majority of men are diagnosed with clinically significant cancer in the first core, another 10% in the second core, but there are a subset that require core 3 and 4, and those cores are typically bracketed around the fusion in case there's registration error. So using this technique, we think we maximize the likelihood of detection in most men. Finally, what about the follow-up imaging itself? So this was a study we recently published, and we looked at men who had PI-RAD 4 or 5 regions of suspicion and a negative MRI-targeted biopsy, just the group we're talking about. Some of those men get lost to follow-up, but about 50% of them underwent a repeat MRI within about a year. And you can see that about a third of them, the PI-RAD 4-5 went away. So that's a critical point, that if it's inflammatory in nature, it may go away. So we never immediately repeat the biopsy unless we're very worried about the patient clinically. We usually will wait 6 to 12 months, repeat the imaging. In another third, it was downgraded, and in another third, it remained PI-RAD 4-5. On repeat biopsy, then, the men who underwent a repeat biopsy, the persistent 4 to 5 showed a 60% cancer detection rate. The downgraded showed 15%, and of course the normalized MRIs didn't get resampled. When we look at the primary thing, we were interested to say, is there anything in the histology that might alert you to the idea that this is a false negative MRI? So we segregated histology in the first biopsy to inflammation, hyperplasia, ASAP or PIN, cancer in adjacent cores, suggestive targeting error, but we saw no predictive ability for any of these particular entities. So in other words, if your first biopsy showed inflammation, you were no less likely to have cancer on a repeat biopsy than if it just showed benign glands alone. So unfortunately, maybe our sample size wasn't large enough, it wasn't predictive. Now, when you went back and did MRIs again in these different groups, you see that a number of the men remained as PI-RAD 4-5, regardless of the histologic entity they primarily had. And this is an example of a gentleman who had a small tumor, and then a year later, you can see at the bottom his tumor's grown. First biopsy is benign, second biopsy shows disease. So I'll close it by saying that my suggestion would be, if you have a PI-RAD 4 biopsy, negative MRI-targeted biopsy, first assess confidence in the biopsy. Are you experienced with MRI-targeted sampling? How many cores did you use? Did you use fusion? Consider early rebiopsy or an alternate method if you're not comfortable. You could send them for an in-bore biopsy if you're unsure. You could do a saturation sample if you're unsure, and look for solid signs of alternate pathology. PIN, for example, at the target sample might explain the finding on the imaging. Assess the accuracy of the imaging. Reader experience, 3T magnet, motion artifact. Repeat the imaging in 6 to 12 months to rule out a false positive. And if the abnormality persists at PI-RAD 3 to 5, I'd suggest you do another biopsy, and you can decide if that should be fusion again or if you want to go to a more saturation approach. In conclusion, not every negative targeted biopsy is wrong, but be suspicious. Your positive predictive value should be around 60% for PI-RADS 4. It should be around 80 to 85% for PI-RAD 5. Good biopsy technique with adequate sampling will reduce the uncertainty. Combine the visual cues from the ultrasound. Do at least 3 cores, preferably 4 from a suspicious target. Utilize systematic sampling in all your patients early on in your learning curve in particular, and rule out false positive imaging. There's no harm in getting a second opinion on the MRI if you're not confident that it's really PI-RAD 4 or 5.